Would you allow me to share my screen, Barb?
Oh yeah, I forgot about that. My apologies.
Uh,
Going to make you a co-host. There
sure.
you go. Cool.
You're a co-host. Okay, perfect. Well, I'm gonna show you. I hope you can see my screen.
Yes, we can.
You see it?
That can you see when I move the slides or no?
Yes.
Okay, perfect. Well, let me know when I can start and sort of how much time I have with you guys.
We tell people this goes to at least 6. So take as much time as you need.
Oh wow, 6. What time is it where you're at now?
It's a little, I don't know, 5 something. Yeah.
52 minutes and beyond.
Okay. Well, thank you so much. And Grant, thank you so much for your words. I mean, I don't think I deserve all that, but I really appreciate you. And
Hush.
you've been a mentor of mine since I started and just guiding me all through the disciplinary committee as well. And I can only thank you for guiding me through this journey. Um, my goal today is to amuse you and entertain you with some food for thought and some facts and some ideas on freediving neuroscience and just basically what happens with your brain when you're on a breath hold and your body. And we're gonna speak about some blackout concepts, how blackout presents, what are prevention measures, and what's in place at the moment to prevent more blackouts and how to act when blackouts happen. Uh, and I like to show this slide to my students sometimes, and even physicians, because in surgery, there was an old physician back in the day in the 1800s. William Osler was a very famous surgeon, and he was the first one to sort of push the idea of teaching medicine at the bedside in the hospital rather than taking years of class and then starting as a brand new doctor, for the first time seeing a patient on your own. He had the idea to teach physicians, students with the patient. So as the patient as the textbook. And this is very moving because in freediving, that's just exactly what I thought when I first saw my first competition, which was vertical blue back in the day. I saw the blackouts. I saw one case of DCS, first time ever myself in freediving. That I saw that I saw lung squeeze, etc. So I realized that there was a gap, meaning there's still a gap. There was back then and now of regular Western medicine and freediving medicine, freediving occurrences. The regular physician is not exposed to freediving incidents, as I realized then. So if I can advise any physician or healthcare provider that wants to know about freediving, if you want to, like Osler said, if you want to learn medicine, talk to the patient. And in freediving, the analogy, my idea is, if you want to learn freediving medicine, you have to talk to the athletes because they're going to teach you, whether you're a physician or an engineer or anything like that. Uh, they're going to teach you what they go through, and that's how you come to your conclusions. My disclosures: first of all, I'm a member of AIDA Medical, and I'm the medical director of the federation in the U.S. But I have no financial relationships with any company, brands. Basically, I'm not selling you anything. And I want to dedicate this to Carla Hansen, late past president of AIDA, who is responsible for me being here, really, to share with you guys. She helped me get into the medical committee and the disciplinary committee. And AIDA approved a mini neuro exam back in 2018 to teach divers how to do a neuro exam, one-on-one without being a physician, and try to catch decompression illness early. And yeah, this was back in the day when we met in Fort Lauderdale with Rob King. I started this in 2014, and I started seeing this. And vertical blue became, on any competition for that matter, became to me like a big laboratory because I saw things that I never seen before, even from a neuroscience or neurological background. Blackouts, multiple presentations of hypoxia. I never saw that in a presentation or a book or a lecture. I just saw it for first time. And I started working, thankfully, I was privileged to be in touch with the medical committee in AIDA, and we started putting names to things. We created a statistic. We look at the statistics of 10 years of competition. We generated this neuro exam, et cetera, et cetera. And at the end of the talk, I will show you what we came up at the federation level in regards to incident grading. Yes, I am a competitive freediver. My max depth is 70 meters and 69 in competition, et cetera, et cetera. But I cannot recommend you to go into competitive freediving myself because it's too risky. Although, of course, you will do it regardless. And if I see you in the water, my job is to safety you and keep you safe if I can. The objectives of today's mini seminar are to understand basic brain functions during freediving. What is a blackout, risk factors for blackout, risk assessment, and understanding the spectrum of blackout. So this is something to make you think. This next 5 minutes. So you ask yourself, I don't know if your audiences are all instructors or scientists and whatnot, but so why are we able to free dive so well once we're born, really, you know? And I like to go back to basics sometimes when I want to understand things. And in freediving, it's fair to say, the more I learn, the less I know. And the one that you really want to listen to is the person who doesn't have all the answers, but has the right questions when it comes to science. If someone tells you they know it all about freediving science, it's probably not true. Evolution, our DNA, or exposure are known factors that can make you adapt. If you believe in evolution or not, it makes you adapt, whether you feel like your life starts at day 0 to day 100 or year 100. It makes you adapt. So we know that babies are able to have this innate congenital diving reflex or diving behavior: open their eyes underwater, close their glottis, close their vocal cords, do breath hold, and start basically swimming. Yeah. And with no fins, if you will. They didn't never get a certification or a class or anything. They just do. And that makes me bring up this hypothesis. Whether you want to believe it or not, I'm not really selling this to you, but this is not new. This was described in the 70s, the aquatic ape hypothesis. And again, there's multiple ways to debunk the hypothesis, but it makes you think. It makes you think because when you compare yourself to other primates, so if we consider ourselves like evolved primates, we can swim, we can actually dive, and very few types of apes or primitive primates can do that. Actually, most cannot. If we compare ourselves to more primitive primates, and I'm no anthropologist by any means, but one of the biggest differences is to be able to stand erect, upright. And it tells you a lot when you look up at the skeleton of a primate to a human or Homo sapiens, the curves of your spine, it makes you wonder, is that really done to make us walk? Or is that really that way to make us more streamlined? We know that the spine, compared to other organs in our bodies, is not as evolved. Our eyes are very evolved, our hands are very evolved, our frontal lobes are very evolved to think, to have social interactions, morale, virtue, values, whatever you want to call it, but not our spines. Why? Because everybody goes to the doctor for back pain. So our spines are really not that great. They're not like the Ferrari, like our brain, They're more like an old car that gets old really fast. But why is that? Why are we there? It's very important to see that why these differences make some sense when you compare your ability to swim underwater, Homo sapiens, with a more primitive ape. Why do we have these changes in our fingers? It's postulated that you can grab onto the rocks better to get out of the ocean, for example, or why our feet are different than a primitive ape or gorilla because we have more surface area for finning, or why your larynx is more retracted back to be protected from the water. There's so many things that you can think of, but a very interesting part of this theory is why our brain develops so different compared to other apes. The usual Darwin theory is that and I'm no historian or anthropologist by any means, but we were apes, we were in the trees, then somehow we decided over some exposure to come down and make fire, right? But this theory actually talks about the possibility of a branch of those primitive apes to go and migrate towards the ocean. Currently, now we know that a great percentage of the world's population lives close to the ocean, close to shore. And why our brains then develop so much? Is our brains are such a fine-tuned machine, better than any computer, if you want to compare as such. Because you need fatty acids and you need specific diet to have brain evolution and brain development. And you obtain those fatty acids from diet that is heavy on fatty acids. And what is heavy on fatty acids? It's shellfish, seafood, basically. If you compare our fat composition compared to marine mammals, it's only obvious that we as humans, compared to, let's say, primitive apes, we're able to, have no hair, so less drag, and have a congenital wetsuit, if you will, to protect yourself against exposure. In any case, I don't know if this is fantasy or evidence. I have no way to tell you, but it made me think a lot, and maybe make it more romantic when you think about freediving. Now, then it made me think of how is your brain really protected when you do breath hold, which is something so counterintuitive. Why we're able to survive so well, and even more with training. So we know that we are born with these mechanisms of preservation. We know that we're born with the dive reflex. We used to call it mammalian dive reflex, but it's really a dive reflex that is present not only in mammals, but also in other marine animals. So this is a study that we published with the Coma Science Group about 4 years ago. An elite freediver that you may know, Ilham Nedi, did a 6 minutes dry breath hold on a functional MRI. And their idea was to look at brain functioning. And they did collect very, very interesting data in regards to oxygen, etc. But most importantly, they collected data on brain function. The functional MRI basically looks at brain activity and tells you which areas are more activated than others. And when you look at baseline compared to apnea, there's a whole bunch of colors, right? So the more activated is orange, less is blue. And there's also changes on the EEG, the electroencephalogram, when you compare alpha waves, for example, and delta waves on the left side. But the researchers back then posted this on Instagram, I remember. It was like a obscure post. But there was no, and so I reached out to them, and I really wanted to read that paper. But they didn't publish it, even having this cool data, because they didn't know if it was significant or it really said, told a story. And perhaps it didn't make sense to them. So I asked them, I reached out to them and I told them, if any of you were free divers, and they said no. And I said, well, I'm a free diver. It makes sense to me. And they say, well, send us a paragraph and tell us what you think. So I sent them a paragraph. And when I looked at this MRI, I looked at what's lighting up when you're doing apnea. Your occipital cortex is lighting up more when you're doing apnea in this MRI. And that tells me that that the area that we use to visualize, to see or imagine visual images, whether you are with eyes closed or open, That's lighting up when we're doing apnea. And that made no sense to them, perhaps, but to me, it made all the sense in the world, because when I took my first day of my very first class in Long Island, Bahamas, for freediving, I was told that I should visualize, and I was told that I should go to my happy place, if you will, if we're doing static, because I don't know, correct me if I'm wrong, but if you're doing a good static, very pleasant static, you're going to some sort of happy, comfortable place in your mind. You imagine your childhood home, or your childhood pet, or your first car, or something like that, or your parents. So that made sense to me. The limbic system lit up too as well, the amygdala. And that to me made all the sense, because when you were doing static, at least, or a good long breath hold, and you really want to have a pleasant breath hold, you want to feel happy emotions. And the limbic system is involved with emotion. You want to feel sensations or feelings of love, compassion, inclusion, or whatever you feel that is good to feel, not anger or remorse. So that to me made a lot of sense. When you're doing a nice static, you have happy emotions. Emotions are involved. The motor cortex that you see in the area on the top, that is lighting up less on apnea. It made sense to me, because when you are doing a static, you're trying not to move. So all in all, what I'm looking at this confirm what I had in my mind for a couple of years before, that your brain is really working in a way to preserve your life underwater and to perform, especially in an amazing freediver like in this case. Uh, there's plenty of literature that describes increased blood flow to your brain, and it's part of it's a consequence of the dive reflex. The dive reflex is multiple things at the same time: bradycardia, low heart rate, splenic contraction, peripheral vasoconstriction, and what we call blood shift, blood volume coming from your extremities to your core. And where does your heart pumps blood to your brain almost directly, going up. So it's basically, I make the analogy of the pilot of the plane. You know, if the plane is low on fuel, the pilot will probably throw a couple of luggages off through the window, maybe cut the doors, turn off a couple engines, and sort of fly in fumes, right? So your brain it's innately able to protect itself by shutting down the areas that are less important to being alive, not awake, but alive. And the area that is the most important to be alive is your brain stem, is the most primitive part of your brain, along with your limbic system. We share that with primates, invertebrates, fish, other animals, and that makes us have a heart rate and breathing when we're unconscious. So your brainstem's working, and when your brain senses that there's less blood flow or less oxygen, your brain is programmed already to shut down, to conserve its architecture. And there's plenty of literature that describing the increased CO2 increases your cerebral blood flow, the amount of blood going to your brain. And this is a product of blood shift, blood going to your heart, going up your arteries, carotid arteries, vertebral arteries, into your brain. Now, this is a video of the operating room at an unknown location.
A lot more relaxed.
This is a picture when you're in the OR, you see the brain, there's some pathology that is causing brain edema. What we would do in these situations is ask the anesthesiologist actually to hyperventilate the patient, meaning I ask the anesthesiologist to tell me what is the exhaled CO2. If they tell me the exhaled CO2 is, let's say, 40 or 35, I know that for an adult human, normal CO2 values are between 35 and 45. So I want that CO2 low. Why? Because I want less blood flow to the brain, for the brain to relax. And this is what we do in our freediving 101, any agency. If you hyperventilate, it is a known risk factor for blacking out. If you hyperventilate, you feel tingling and a little bit of just euphoria. And that's a product of less blood flow to your brain in layman terms. And that's a proof to when I tell my students, when you hyperventilate too much, you are decreasing blood flow to your brain. That's a risk of blacking out, in my book, at least, from my opinion, and it's the opinion of many. Now, brain pulsations are not very light. They're not very light. So you see these pulsations. This is a picture of a surgery through an endoscope, and you see each pulsation represents your heartbeat. So your heartbeat is transmitted to your brain through blood. And literature also describes increases in pulsations in your brain, even after one quick breath hold. In this case, after a breath hold of 21 seconds, there's more pulsations into your brain. That means that your brain unconsciously is redirecting blood to itself to continue being alive and protecting the most important part of your consciousness, the hardware, your brain. What happens to our lungs and heart when we free dive? This is important too, because what I found is that not only you trigger the dive reflex, this preservation mechanism to your brain. Not only you trigger that in the water, but you can trigger it on dry. And I'll show you these quick videos of myself. I took this in 2023. This is a live X-ray of my own chest. On this side, if I'm looking at the screen, on my right side is my left chest. The other side is my right chest. You'll see my heart on the left chest mostly.
Let me know.
And here I'm doing.
Or to exhale, revert back.
I'm doing an exhale, and you can see the heart gets bigger. And with each exhale and reverse back, I don't know if you know the term reverse back or not, but it's when you use your mouth to pump air out of your lungs. With each reverse back, you decrease the volume of your lungs, you make the heart bigger from blood shift, and you make the diaphragm sort of bend in between the thoracic cage and the heart. It's pretty dramatic. And I did that just to prove to myself what happens to my lungs and heart when I dive deep, right? Because this is what happens when you dive deep.
That's fine.
And I'm going to show you, this one is more probably a much better picture. This is also my chest. You can see my heart. You can see on my left side, my stomach, because it has gas there. On my right side, you see it all dense. It's the liver. You can count probably 10 ribs, maybe. See, 1, 2, 3, 4, 5, 6, 7, 8, maybe 9. And I'm going to show you, first, I'm going to start inhaling there. You see, now full inhale to a maximum inhale is called total lung capacity. Is when you just do one big inhale and hold it. If I start doing packing, which in medical terms is called glossopharyngeal insufflation, it's just using your mouth as a pump to pump air even more against the pressure of your lungs. And I'm doing so here. You see, with each pump, with each pack, as you can see, my nose clip is sort of moving at the top. You can see the lungs sort of angles getting lower and lower and lower and slightly bigger. And you can see the heart is a little bit sort of compressed. And that's important because I don't know if you've ever seen a blackout on dry of somebody packing, but if you sit upright, not alone, and if you're in a group and you're doing a breath hold on packing, I've seen at least twice, I've seen LMC and blackout. I've seen blackout once and LMC once. And if you do it standing, you're definitely higher risk. Why? Because you're compressing your heart, you're compressing the pump. You're not letting the pump blood. If you're not letting blood into your brain, you can black out, you can lose consciousness. Now you'll see me exhaling to residual volume, right? When you exhale and you do this. Now, if you go below residual volume, you have to reverse back, which is doing this. And that's what I did here. You can see my nose clip up, sort of like the shadow of it, and sort of moving with each reverse back. And with each reverse pack, you see the diaphragm getting higher and higher and higher and higher. And that's exactly what happens when you're diving deep. This is you diving deep. I love this video because it really shows me how the diaphragm needs to be so flexible and how the heart needs to take all that blood. The heart goes from this shape to the shape of a boot almost. And your heart needs to be healthy for freediving. It's not that this really confirms my idea of this is not the same dive for everyone. If someone 20 years old or someone 60 years old, if doing a 50-meter dive, it's not the same dive. It is not the same physiological stress. And therefore, a lung squeeze, which we will discuss later, is not the same for a 20-year-old or a 60-year-old. It's not the same lung squeeze. Even with the same amount of injury, it's not the same pathology because the 60-year-old will be a higher risk. The diabetic will be a higher risk. The person, the diver with a heart history, smoker, COPD, it will be a higher risk. Very important. And then I'll just finish this video showing you the exhale. Very interesting. And you see how the veins get engorged, all these veins here. That's blood shift. You see how the vein gets really engorged here. That's blood shift all the way. And you know how I knew it was blood shift? Because I wanted to go to the restroom to pee pretty much right away. And that confirms it. To me, that confirms it. And then I started another inhale. I don't recommend you to try this. Definitely not under X-ray because it's risky. And I don't know what your level of training is in freediving, but this I teach to some students how the risk of blacking out from going, you're ready to do your first dive, you map it out, you know where you're gonna go, and then you get excited, and then this is a very famous swim through or dive through in Roatan, near West Bay. It's very interesting that if you get excited about a target, I feel like the more I get excited about a target, the more mistakes I tend to make. If I tell myself I gotta get to 50 or to 70 or to 75, I gotta get there, I gotta get to the end or something. I tend to make more mistakes about my breathing, about controlling my thoughts and emotions in general. So, and then this is the last thing you see, and the next thing you see is this. This is what you don't want to see. You don't want to wake up and looking at the sky and then having all your friends sort of trying to revive you. That's a blackout, especially if you lose memory of the event. If you have a blackout, that means that loss of consciousness, by definition, you're losing memory of the event. If you have memory of the whole event, whatever happened in the session, you likely didn't have lose consciousness because you're conscious of the events, the time you spent. But if you have amnesia, if you cannot remember, you likely lost consciousness, and you have to consider that, determine that's a blackout. It's usually minimized or underreported, perhaps. It's unlikely for the diving community to come up to the medic in the competition and say, I had 5 blackouts in the last 6 months, and I'm going for my national record tomorrow. It's more likely that you will say nothing and you're healthy and you just continue. And it's not, it's just part of human behavior, including myself and everyone. We just tend to do that. We just tend to take risks. Untrained freediver and certified freediving is a high risk factor in my mind. And every time an incident happens, you need to learn what happened to you. So loss of consciousness, loss of motor control, loss of airway control is very important. And the inability to keep your airways above water is, by the rules, at least consider a blackout. And all freedivers are at risk of hypoxic syncope or blackout, right? About 4,000 people die in the States from unintentional drowning. And in competitive freediving, and looking at the statistics, there was about 3% incidence of DQBO, which is disqualified by blackout, on 10 years of competition. We published this at the UHMS meeting a couple of years ago. And looking at the statistics on those 10 years, there were so many white cards, etc., and so many red cards. But in competitions, we don't document blackout. Well, at least then, they didn't document blackout or lung squeeze. They're just cards: red card, white card, yellow card. But there's a classification within red card is DQBO, disqualified by blackout. And if you just look at those, which may not represent all the blackouts and all the hypoxia, you go to 3%. So approximately 3%. If you look at year by year, the incidence of DQBO doesn't jump a lot, doesn't change a lot. That tells me that behavior in those 10 years, at least behavior in competitive freediving, didn't change a whole lot. It's not like it changed from 3% blackouts to 10% blackouts. You know, we didn't cut a lot of corners, if you will, from year to year. If you compare the incidence between pool dynamic, and depth, it's interesting that in pool dynamic, the incidence is slightly higher, perhaps because in a pool, we feel like that we're definitely closer to the surface. So if anything happens, you're only a couple feet from the surface at the most. Therefore, perhaps we tend to push ourselves more. If you compare between disciplines, we know already that constant weight no fins is the highest risk because it's the most difficult one. It uses the most muscles, and it acts against your blood shift to a degree because your blood shift is shifting blood from your periphery to your core. But if you're doing no fins and using your arms and legs, you're acting against that because your muscles need blood flow as well. There's no statistical difference between genders, although there was a slightly higher incidence in males. And this slide basically tells you the deeper you announce, the higher risk of blacking out. The deeper you announce in each discipline, and CNF being the highest risk, it just makes all the sense because we knew this. And the closest you announce to the world record, also you have, if you higher risk. If you announce, let's say, 90% of the world record, your risk is highest, 12%. So basically, the deeper you go, and the more you want to break that world record, the deeper you go on that, the higher risk for you to black out. Risk factors for blackout are many. In general, in medical terms, dehydration, poor sleep are big ones. Pushing your limits are all other technical risk factors. Recent hypoxic event or blackout, that's not studied yet, but it only makes common sense that if I've had a blackout yesterday and I'm doing today another big attempt, it's just I have sensed that the risk is slightly higher. If I had a blackout today and I'm doing another big dive PB personal best today, the risk is definitely higher in my mind. So I wouldn't do it. And I bring this to your attention in regarding the breathe up. What we used to call breathe up before, now it's called relaxation phase, because you're not supposed to breathe up to your depth performance. You're supposed to relax and basically do not control your breathing. And I'm going to tell you why. So you don't have to know all these terms like TLC, RB. You need to know tidal volume. Tidal volume is the minimum amount of air you can move to be unconsciously breathing. As if you're laying in your bed looking at TV and falling asleep. If you're doing that and you're barely moving air, that's tidal volume. And I tell my students, if you really want to do that well, you have to put a flame next to your lips and barely move the flame with air. Now, what happens when you hyperventilate without knowing, right? This will happen in my first blackout in competition, 2018, where when I thought I knew more than what I do now, obviously, because I didn't know, obviously, back then. And I was nervous on my first dive. I came from work, very tough cases that week, very, very tough cases. And neurosurgery is no joke. It's not easy. It drains the hell out of you. It puts you on your knees, just like freediving puts you on your knees. And this is something I heard from a really good friend, Antonio Del Duca. He said, freediving puts you on your knees. It makes you beg for forgiveness and beg for survival and to overcome your own self. Neurosurgery is the same. It puts you on your knees. So it was a hard week. I didn't sleep well for days. I flew to Roatan. I didn't sleep well. I arrived the day of the registration. I trained some in the pool. And then the next day I announced my first dive of 50 meters or 55. I think it was 55. And so I said, I'm fine, I can do this. And I I went to the plate, I picked up the tag, put the tag, and I remember thinking at the plate, I said, this is my first dive of the week. I'm going to do great. Let's get out of here. I'm fine. I start going up. And then I woke up with the safeties sort of hugging me in a group, right? And I kept doing the okay sign because I didn't know. I didn't know a blackout, so I had a blackout. And right after that, the announcer in the platform told me, Juan, you were hyperventilating. And I said, no, I was not. And when I look at the video, I was nervous enough and tired, mentally drained, that I decided to do a long sigh, sort of to calm yourself. I don't know if you ever do this to try to calm yourself. You do this, sort of like that. That by itself set me back and meant hyperventilation for me. And this is why I did this little experiment at home. I am holding a pulse oximetry on my left middle finger, and holding to my mouth CO2 sensor. Okay. The pulse oximetry reading is 96, which is fine. The CO2 sensor is reading 40, which is normal for an adult. Now look at what happens after I do one long, nice exhale.
40, 97.
So the CO2 dropped to 34. That's the exhale CO2. That's a plus minus 2 when in regards to your blood. That means that just by doing one long sigh, I was already below the normal CO2 and I was already hyperventilated. So basically and you can confirm this with any instructor of any agency, at least Multinos and AIDA, that if you try to manipulate your breath, you are risking hyperventilation. Anytime you manipulate your breath, you're risking to lower your CO2. And that's important because if you lower your CO2, you're putting yourself at risk of blacking out. And as you may know, the reason is hemoglobin in blood changes its configuration and becomes more, it binds oxygen a lot stronger, does not release it to your tissues like brain. Now you may ask, is it safe to do a breath hold on dry, right? We do a lot of breath holds on dry and this and that. And back in when I started freediving, I was told that you can practice static apnea in your bed. And if you black out in bed, well, you're in bed, so you're gonna be fine. You're just gonna wake up from it. But it is not that easy, you know. I was sent this case from a friend in Finland who did a breath hold on dry alone at home with a nose clip and a pulse oximetry. And he had one risk factor, being alone, another risk factor, using facial gear, another risk factor, he did it on RB, which is residual volume, and another risk factor, he hyperventilated before the breath hold, right? If you do it right, it should be fine, right? But he did it, and he extended it. So he did a breath hold. Before bad things happened, he was at minute 3, which is a lot doing on residual volume and hyperventilation. So as you see the graph here, the blue dot is the saturation and the red is the heart rate. You see a drop in the heart rate as is expected from a dive reflex perspective. But then you see irregularities on the heart rate and then a sudden drop of the heart rate. So something's bad happening if the heart rate drops late on the dive, if you will. And your saturation starts dropping slowly like it should. And then there's a dramatic drop on the saturation of O2, which is also worrisome. He ended up having a blackout alone. And the fact that he was alone with a facial gear posed a high health risk because he couldn't take off the nose clip once he was hypoxic. And the message is, once you're hypoxic, you are in grave danger. When you're hypoxic, you're not, if you're hypoxic at home, with facial gear, you better have someone next to you to get that facial gear off and let you breathe, especially if it's a mask or nose clip, right? But if you are, if you're underwater, there's no golden formula to say, oh, I'm hypoxic, but I better rush to the surface. No. Once you're hypoxic and your perception is impaired, you are a potential victim. You're in trouble. You better have a lanyard connected to a line, or you better have a safety next to you to get you up. So he ended up having actually lumbar trauma at home, which is lung squeeze at home on dry without the fins and anything. So the answer is you can get squeezed at home. Okay. Very interesting and very important message of the story. Do not do breath hold at home with facial gear. No, it's a big no-no. And if you're going to do it, you better have somebody next to you. Now, any questions before I continue? Unless we're in the time. If we're in the time, I can cut it short. Go ahead, Barbara.
I think we're good. Let's open
Okay.
it for questions. Yeah.
Okay. So, from a neurosurgery, neurology, whatever perspective, I noticed that a blackout is not the same for everyone. It's not that you start diving and then you have a sudden loss of consciousness. It's a progression. And that means that there's not the same blackout for everyone. And it's not the same blackout every time. If you have a blackout and you have a blackout in a month, it may not look the same at all. It may look completely different. And it may not look the same to your peer who's doing the exact same dive. Okay. So it's in a spectrum, meaning we presented this to the UHMS, but it was not accepted back then. It's a theory that we discussed with Dr. Melikov, the director of AIDA Medical. And this is what we came up with. This is upon observation and anecdotal and my own experience on my own blackouts. I had 6. And there's a hand that is raised that I would like to give if you want to ask a question. It's like Jennifer. You're on mute. You're on mute, Jen.
Here, let me.
Hey, I can wait if you're going to continue to present. It's sort of a curbside.
Okay, sure. I can continue real quick and then.
All right, I'll ask you at the end.
So what we postulated was that a diver doesn't just go into blackout and full loss of consciousness. A diver is conscious first, and then there's a phase of asymptomatic hypoxia where your oxygen starts dropping, but you don't have any symptoms. And there's a phase of symptomatic control hypoxia, meaning the diver is aware of potentially aware of subtle hypoxia, but still is able to control the technique, the form, the propulsion. Meaning, if a diver is very experienced and has done the same dive over and over again, and has had blackouts, not 1, not 2, perhaps many, the diver has more experience in knowing its own body, right? So that diver, that elite diver, is more in tune with what can happen and knows the dive from A to Z. They knows the speed, how the temperature, how things should feel. That's the diver that is able to recognize that something is slightly off in that dive. And when that diver knows that there's something not familiar, it's a little bit off your dive, just something different, that may be hypoxia. And at that time, your perception, your whole awareness is about to just be completely not your friend, is unreliable. Then you go into symptomatic hypoxia, real symptomatic hypoxia, which is loss of motor control, which we call SAMBA. And I noticed that SAMBA is not just just a chaotic, movement. It has a pace. It has a cadence, like a song, like a tempo, right? And there's some specific muscles that contract. I feel like they're the anti-gravitatory muscles that keep you upright. So your erector spinae makes your chest up, and your quads. That's why you start kicking. I don't know if you've seen anybody kick or have samba underwater. they start kicking the legs and going like this up. Those are the muscles that keep you upright. Now Samba can be, or LMC can be conscious when you have full memory of the event, or you can be unconscious when you don't have memory of the event, when it's part of blackout. I feel like Samba or LMC can be a blackout, part of blackout, or not. Because I've had, and I'll show you a video of me doing Samba with no blackout and complete recollection of the event. Once you go into blackout, there's different types. Atonal blackout, meaning you lost complete tone. Deserved posture, if you've seen some divers, elite divers do this posture, like this, an extension. Prolonged hypoxic blackout, which is not, it takes probably minutes to recover. And I'll show you this briefly. So symptomatic control hypoxia, this is with permission of a good friend, John Aristotle. And he's coming up, and you see that, I'm sorry. You see that he's coming up here. And you see that he's already looking up. That is a change there's a change in the technique. It's a change in the pace, because in free immersion, if you do free immersion, you're supposed to glide and sort of relax and wait the glide and then pull and relax and be streamlined. But he's doing this. He's looking up almost to anticipate where is the surface, right? He's changing the position of his legs to start kicking with his legs again. See that? That's not part of the usual technique for pre-immersion. That's meaning I need to get up. This diver here on the left is a very experienced diver. He's so experienced that he not only recognizes signs of hypoxia on the surface, which is the obvious, but he recognizes signs of hypoxia underwater. So he looks at those signs, and then he looks at the other diver as if saying, there's something wrong here. And then he takes the decision to come really close to the diver, like here, there. He knows something's about to happen. And indeed, you see the diver with the arm extended, dragging water, not streamlined anymore, and basically just floating up. That is a blackout. That's a blackout a couple meters underwater. And that's very important. So basically the message is recognizing hypoxia signs underwater can save a life. You can get someone out and you can save a life. That's very important. Conscious LMC, this is my own video of the same safety diver, Chris McKay, in the Bahamas. I come up, I do one hook, 2, 3, 4, and then I start with the Samba. And then I had some assistance. I never lost consciousness. I had full recollection of the event, but it was an LMC. So it's a conscious LMC. That was 65 meters. This is an unconscious LMC. This is my own video as well. My first blackout in competition ever. That was sort of, an embarrassment, but it was it's a blessing in disguise for me. So I was coming up from 55, and for some reason I was so excited. I was kicking. I took my goggles off. I remember for some reason I was just excited. I said, well, that's one more thing to get out of the way, And you see there's current that day. So I was like fighting the current and trying to grab the line. I took already my goggles off. So I was just saying, I'm going to get up, get my nose strip and be done with it, right? So you see me kind of kicking, fighting the current slightly. And then just before I break the surface, you see my left hand shake. Right there. My left hand starts doing this, right? So that's a Samba. That's I believe that must have been unconscious Samba by that time. And then the camera pans out because I blacked out. And you see me kicking. You see me, my quads are contracted. You see me kicking, arch backwards. So that's a full LMC, unconscious LMC. That was a blackout. Syncope, I show you this one. So syncope is when you actually lose consciousness. And this is the same video of my friend who gave me permission to show you this. He's blacked out. The usual rescue sequence is blow, tap, talk, or blow, talk, depending on what agency you follow. And if three rounds of that doesn't make them come back, then you start rescue breaths where you actually breathe into their mouth or their nose, as most lately adopted. And 3 rounds of that, more times than not, makes them have them wake up. And you see him after 3 rounds of rescue breaths, he's back, like nothing happened. You know? What is different and sort of interesting is that if you saw this, if let's say you were an EMT or a ER physician, and you saw this in an ER, in an ambulance, you will immediately be getting your tube and your medications to paralyze that patient and intubate that patient, getting ready into the ventilator, right? In freediving is different. It's not that you want to put him down to put a tube in their throat, like one would do in a hospital. That diver is trying to wake up. The diver is trying to be alive. So you have to help them wake up. So whether by sitting them up and giving them positive pressure or oxygen, right?
Yanni, why don't we wrap up and ask questions and stuff?
Yeah, let's wrap up. Let's do that. Yeah, I'm gonna end up with that slide. Very important to recognize that it's very different a surface blackout than a deep blackout. Deep blackout is basically a drowning victim because you have distress underwater while swimming. Okay, it's no joke. You have to be aware of this. And just to finish up, this is the last slide I'm going to show you. Go ahead. Hello.
I often the heart rate is higher after trigger the mammalian diving response when I sleep. It is normal. Is it like a sign of recovery?
I'm sorry, can you repeat that again?
So I found that the rest heart rate is higher after people trigger the mammalian diving response. Is this like normal? Is it a sign of recovery?
I don't know that answer. I mean, if you're dehydrated after a dive session, your heart rate may be higher. So that's probably why. I cannot really speculate if it's recovery or not. No.
Okay. Sorry, I have another question. I found that contractions happens more when I do the CO2 tolerance training compared to the low oxygen. What is the reason for that?
Can you repeat that? I'm sorry, I can't hear you very well. You were cutting out.
Contractions happens more when I do the CO2 tolerance training compared to the low oxygen.
Mm-hmm. Yanni, she's noticing higher contraction rate earlier initiation when she does CO2 tolerance. I would assume it's the lower pH and higher CO2 that drives it.
Right. So the theory tells us that CO2 is the only, I say only like this, only trigger or for contractions, right? But that's what we think, at least. Is that the fact? 100% the fact? We don't know that. We don't know if oxygen is another trigger, but perhaps CO2 is the biggest trigger of contractions. And that's probably why you're having obviously CO2 table triggers more CO2 buildup, and that's why you're having more contractions.
So if a diver...
Sherry, here's an interesting observation for the people that do oxygen-aided breath holds. Contractions come on much later. So it for me, that points to the pH, not purely the levels of CO2, because oxygenated, the oxygen breathing aided pre-breathing of oxygen prior to a breath hold, CO2 levels get really high, but I think the increased oxygen provides a buffer for the pH. So they'll initiate contractions much later into a much longer breath hold. So it's not just the molecules, it's actually the blood acidity.
Thank you. So if a diver have a really good CO2 tolerance, before he black out, is he gonna have contractions? You know what I mean?
It's hard to say. I mean, because they lose memory and it's hard for them to remember the moments or seconds before a blackout. I don't have that answer.
elite athletes will often mentally train away contractions and symptoms where they may just not experience anything versus a brand new person that's much more dictated by pure physiology and not mentally trained. So it's hard to say, as you say.
It's such an individualized thing. Yeah.
Well, and training effect is real. So an elite athlete can condition themselves, one, to initiate mammalian dive reflex and splenic contractions literally by smelling a wetsuit almost, or their first relaxed breath. We've seen with ultrasound that splenic contraction happens on a conditioned athlete within the first 10 seconds of holding breath, where it can take up to 2 minutes on an untrained person. So there's real impacts of mental training and physio training and training effect. Sorry, Young, go ahead.
Oh, it's fine. No,
There's a question in the chat about training programs, the dry training programs that are available on apps. Do you recommend those? And, maybe what are the things that you look for? For a beginner, maybe trying to get better, level 1 to level 2.
I feel like any basic CO2 table is not bad. I mean, you need to train your breath and you need to know your breath. If you're a beginner and you want to increase your breath hold, yes, CO2 tables are good, but I would recommend to do that with somebody at home, especially if you're a beginner, you haven't been exposed to breath hold a lot. You may have an undiagnosed medical issues that you don't know, or you don't know how your body will react to long breath holds. So yeah, I'd rather have somebody at home that will be monitoring you or checking on you. That's
a great plug for getting some training. I can't tell you how many people come to me and they don't think they need training, So, Grant?
Yanni, I'm curious what you think in general about the variability of timing of blackouts in more recreational level divers. It can be so different, and that's why we always say use safety. Have you found anything in the physio side of it? Is it not enough recovery breathing? Is it higher level of CO2, more diving? And then some days we see people that have blackouts that's seemingly easy dives for them, but on that given day, it's just a bad day. Do you have any physio reasoning behind or thoughts of what might create that variability?
Not really, no, but you bring up a really good point. One would think, and even insurance companies imagine that competitive freediving is riskier than recreational freediving, which in fact, in my opinion, a recreational freediver is extremely risky. Because in a competition, as you know, everything is made for you to survive. Everything is tailored so that the athlete is alive and continues to be alive, even if something happens. But you don't have that safety net in a competition. I'm sorry, in a pool or in a spring or the lake. There's nothing. There's no medic. There's no AED or nothing. It's not even a proper safety, perhaps. So if you're doing recreational freediving, be careful. You have to do risk assessment, risk mitigation, know the field, know the closest hospital, get a good phone, evacuation vehicle. Read my article on the Dan.org, the last issue from Q4 2023. I wrote an article on risk assessment and mitigation. Read that. That's very good. But recreational freediving is very dangerous. And I feel like, to your point, a human behavior. It's more relaxed. And if you're going and in a boat, for example, you have beer on the boat, everything is more relaxed. So therefore, more chances of making a mistake,
Other questions?
What do you think about the dry apnea training compared to like the pool and ocean wet conditions?
You're cutting out. I'm sorry. You're cutting out, so I cannot hear you very well.
So I believe the question was,
what do you think about
dry training versus pool training or ocean training? Is one better than the other?
If somebody
No, you cannot
some
compare.
people like yeah, I heard different suggestions about someone said it's useful, some said it's like useless. So what do you think about like dry apnea, is it worse spend time on it?
No, any training is good, but it just depends on your level of training. And I'm not a 100-meter diver either. So if you're beginning, you should do CO2 tables and train in the pool with a proper safety or a coach or an instructor. Every training is good for you, but it depends on what your goal is. If your goal is to do underwater endurance, for example, then you need to go to the gym more. If your goal is to do just a long breath hold on static, then that's a different way to train. It's more aerobic exercise, mental tables. So I don't think I don't think you can compare one is better than the other. But they all complement each other. You cannot just do pool only unless you want to do pool, but you have to complement with gym as well, and CO2 tables and regular breath holds. So it's all part of the same.
Okay, thank you. And Jennifer, I think you had a question.
I can address that last one a little bit.
Yes, thanks. So,
oh, go ahead. Go ahead.
You know, if somebody needed like a medical clearance in LA with a possible history of possible cardiac history, pediatric cardiac history, who would you send them to? I've got basically my kid's a recreational freediver, but now he's 19. He's freediving in the history of he has an undefined cardiomyopathy, and I'm so not okay with it. But he had, when his workup started, his ejection fraction was like 40 to 50, and now he's 50. And he has no structural problems, no history of arrhythmia, but his workup started because of syncope at age 16. But I think in hindsight, he was probably smoking a lot of dope, weed. But now I just think he needs like a good pulmonary and good cardiopulmonary clearance. And but he feels like he's been cleared. And I'm so not okay with any of it, especially after listening to you.
I would call the Divers Alert Network and get a referral, or
who is that?
Medical Society. I would call the Divers Alert Network.
Dan,
the medical line, and get a referral to a certified hyperbaric and hopefully cardiologist in LA, and get him checked. A history of syncope is exceedingly dangerous in freediving unless he has one-on-one safety, and even then, syncope in any aquatic sport, even swimming, can be. And Yanni, tell me if I'm wrong, but syncope is a big rejector.
I mean, I agree. Although
I am definitely concerned about that output fraction as well. And it, the scans that Yanni's shown is awesome to show just how much interthoracic pressure and blood shift happens, and it's not for the faint of heart, literally.
Right. Yeah, you're right. You're right. You need a good cardiologist to see him, and a good pulmonologist as well, and maybe a sports physician to really see. It has to be a cardiologist that understands breath holding, which not many. And maybe it would be good to do some tests on breath hold to see how the heart's behaving.
Shane Hawkins retired, but he's gone now.
So I missed the beginning of your conversation, but I'd like to see you said you have a publication in Dan, a risk assessment publication. Can you throw the citation in the chat? Or
I'll go ahead and publish that. I'll go ahead and post the meeting. Yeah.
All right. Thanks. Anyway, thank you though. That was very informative and incredibly scary.
Yeah, I'm sorry.
You guys are nuts.
We're not about to scare you, and this is elite level stuff. It's not with good safety. Recreational freediving is very, very, very safe.
He's in the Berry Islands. I don't know if you know any of the outfitters there are the Berry Islands, but that's where he's doing most of his diving in the Bahamas.
Wow. Okay. That's a whole different conversation that Yanni and I know very well from spending quite a bit of time on little islands in the Bahamas. Barb, what's the name of the physician that was a hyperbaric physician at UCLA that's, I think, just retired? Is she still in practice? Is it Joe?
No, Joe Feldman's.
Oh, yeah, Joe. I know her. But
I
she's
would talk to
retired.
her and get a referral
She
from her.
retired, right? Susan Sproul, that's it. Thank you. Thank you.
Susan,
Thank you. Perfect.
She's awesome.
Yeah, all right. And maybe Sproul's a good idea. Okay. That's a really great idea. Thank you.
Thank you for your
Okay.
question. Any other questions?
We're here to help.
All right. Well, I don't want to take up any more of your time. I'm really excited that we had this today. Yeah, so thank you to Yanni and for all of you being here this evening. I'm going to go ahead and stop the recording. If I can find the button. Sorry.
Thank you.
Yeah. Just briefly, I want to ask